business runs several hundred offices in 10 countries around the world, from Germany to California to Japan to India to Brazil. And we were at the front lines as things started shutting down in Europe and then cascading across. And we've been thinking through, how's the workplace going to have to be different just on the first day back, and then maybe the first quarter back. And the workplace is going to have to be different. And some of those ideas we've been sharing with folks, and we're certainly working with our customers on these. I was quite pleased and surprised to see Knotel in a National Geographic article a couple of days ago with some of this stuff about better ventilation and better monitoring and all that. But in a way, all these ideas are thinking a little too small. And that was what was exciting when you reached out to me last week. It's like, if there's a problem, I guess you can try to address the problem in a really narrow and specific way, or you can use it as an opportunity to really just transform. And I guess, that's the kind of stuff you've been doing for your whole career. Starting companies, building companies. I think you've been at it since before AI even worked. And the X Prize has never been short on ambition. Do you want to give a few lines of the different places you've been involved and the kinds of things that you've been thinking about these last few years, and then we'll turn to what you're thinking about now?
Yeah, thanks, Amal, for hosting today, and it's great to be with everyone today. And I guess, Amal, will there be time for Q&A later? If people have questions, I'm happy to answer the questions. If people are able to ask questions either by email to Musa or some other way, happy to answer.
Yeah, here in the Zoom thing, there'll be some QA type questions. I'll keep track of it.
Okay,
and I'll
great.
surface them.
Okay,
and I think someone is periscoping our conversation, which I guess I'm fine with. Jolie, you're fine.
Yeah, I just would rather not, kind of keep it out of the really not. It's not really for press. It's really just for the Knotel community. So,
well, then Periscope won't really let you limit it. And the folks who are tuned in here, I think, Jack, you should just assume that it could be anyone, right? So
if
there's some stuff you want to edit in your commentary.
No, there's nothing proprietary here at all. Just really want to focus on the Knotel community and focus on that today. But anyway, great. Well, great to be here with everybody. And so, as Amal mentioned, I've been an entrepreneur for most of my career. I started in science and then built a number of companies, built Earthweb Dice.
Jack, we kind of did similar stuff early in our career, right? I mean, neuroscience and philosophy at Columbia is basically my academic background too. I mean, I happen to go on and do.
That's right. Yeah, neuroscience and basically I combined three passions in my kind of research part of my career, which was computer science, neuroscience, and physics. And that led to my work at NIH as a Stanley Fellow there, where my research focused on functional neuroimaging, which is where you use an MRI machine to and speed it up, kind of like how they did in the 1890s with photography, where you would photograph that horse and put the photos together. And they said, wow, we've got moving images. You can kind of do something similar with an MRI machine. And at NIH, we had some of the early work in that area. And that really combined the physics of MRI itself to understand how that machine was working and how to tweak that machine. And then the neuroscience, obviously, what was happening in the brain that we were watching, because with an fast MRI, you can look at what the brain is doing, not just the structure of the brain, but the function of the brain, of course, as you know. And then, of course, the computer science. I had started coding when I was about 11 years old, growing up in Brooklyn, New York, and always had a passion for coding and still do that today. I just taught a course in Python just 2 months ago before COVID hit. So that continues till today. And it's been great to combine those passions. And I'm very lucky and very honored to have the ability to continue to combine those passions and other passions now as well. So over the time, I created companies such as Earthweb Dice, which is a company that focuses on the needs of IT professionals and still going strong many years after I had co-founded it with my brother and Nova Spivak. And that company focuses on IT jobs. Dice.com is still going strong and is a public company on the New York Stock Exchange. And so it's great to see your progeny, continue on in this way and still continues to serve about 6,000-7,000 big companies and small, medium-sized companies every year to get their IT departments connected with the skill sets they need. And then went on to create another company in the fintech space, sold out to S&P, and then spent a bunch of time setting up a foundation and focused on a number of areas, but clean energy, oncology, work in oncology, and education, three of the key areas that I focused on the last 10 years specifically. And now, again, combining a lot of my passions, putting a lot of time in AI and how AI can be transformative for our world, putting a lot of time in quantum computing, and recently wrote a book on that has become a textbook in many courses at many of the leading universities. And so always been passionate, Amol, like you have been, around the emerging technologies and how we can harness them for good and how we can have an impact with them. So with XPRIZE, you mentioned I'm on the board of XPRIZE, which I am, and been really a privilege to work with Peter Diamandis and many others at XPRIZE over many years as a board member, and really, think in the largest of terms from the point of view of how do we impact the world by addressing some of the grand challenges that often are left by the wayside. You might say, well, how are the grandest challenges left by the wayside? And it turns out that often you have a tragedy of the commons, where if you have a smaller kind of issues, very local issues, they might be tackled, by some local folks. But sometimes the grandest challenges are only those that can be kind of coordinated among many, many stakeholders. And sometimes that doesn't happen. The market isn't always efficient in those contexts. And so the XPRIZE has been very instrumental in opening up space to private enterprise and focused on telemedicine. I'll mention one of the themes here was really catalyzed in part by an XPRIZE focused on telemedicine and some others. So with that, maybe I should begin, Amol, unless there's anything else you want to add.
Yeah, long history of thinking big new ideas. Although the office was not mentioned in your life heretofore. I suppose you've been in some offices.
Yeah, once
but
in a while.
Now it's front and center, right? So let's do it.
Good. So, a number of us have come together and are really thinking hard about how do we emerge, in what economy, what structure do we emerge as we emerge in a post-COVID scenario. And I think that we can all agree on this call here today that this is a very, very large opportunity for us to rethink, restart in a very different way than we had. I know that a lot of the politicians are under a lot of pressure right now to open the economy. And what we hear from them is that they want to basically open up the old economy, talk of opening up, the restaurants and all that stuff. And we completely understand the desire to open up economically and get economic drive going and jobs going, and completely agree that we need to focus on people's economic well-being, even as we also focus on public health. But as we look at those two areas of public health and well-being, given the COVID scenario, and looking at economic well-being, we realize that there's really an opportunity for a third way. And so I'll be touching upon four themes here.
Jack, it's not even a mere opportunity. I mean, my view is that it's just a necessity. There is no
imperative. Yeah, probably imperative is the best way to say it. Yeah.
Yeah, we're not going back. We will be back, but we're not going back to the old way.
Well, yeah, but I think it's going to take some intentionality. That's I think what we're trying to say, that in our conversations with be it governments or others, what's clear is that without those of us who have been in the vanguard of thinking innovative thoughts, really engaging and leaning in on this, it will be attempted to go back to the old way. And I agree with you, that old way is gone, but that's not going to stop lots of folks from thinking it's possible to go back to the old way. And so that's actually one of the big challenges now, is that perceptual challenge. And that's what we always found in every XPRIZE and every challenge that I've been involved with. It's the mental and psychological barrier that's the biggest, and the technological one and structural one actually is smaller than that one. And so I think we have something similar here. The first big challenge we have is to overcome the mental barrier that we are not going back. We don't want to go back to what we just left. We actually want to move forward into something new. And I know amongst the folks on this call, that might be bread and butter. That's fine. But in the engagement with lots of other communities out there who are not folks who regularly imbibe Singularity Network videos or TED videos, there is a wider set of folks who we need to engage with in order to bring into this new world. So I think that our work is clear. We need to actually engage and not take it as an assumption. And based on our conversations with lots of companies and CEOs, we can have a big impact. One conversation with the CEO of a company could literally turn the future of that company and then domino into more impact. And I think that we know some of the reasons why we don't want to go back. And Amol and I have been discussing this. We think about the healthcare system we just left and are in right now. It's a disaster. It's a sick care system. We don't want to go back to a sick care system. It's not a wellness system. We'll get more into that today. The lack of productivity and low quality of life for all walks of life was evident in the old economy. Obviously for folks in the low income category, very, very difficult. And then even folks with, quote, great jobs, commuting an hour and a half each way each day, not seeing kids, not able to access education, even if one has a solid and decent job, the ability to access education is limited, particularly for professional development, to really jump, the ladder. The pollution and the impact on health and well-being of pollution that we have in our communities, and also, of course, the carbon impact, and then, of course, biases, structural biases throughout the system, and then brittle supply chains. The fact that we couldn't build enough medical devices to address COVID in a quick way just is revealing of this brittle supply chain that we have. So the good news is that this moment gives us a mass opportunity to rethink all these types of status quo issues. And what's presented to us often in conventional wisdom is this trade-off of the red line that, hey, what would you like? Would you like to save grandma? In which case we'll have to keep the economy shut and we'll save grandma. Or let's open the economy and we'll have to assume some casualties, some collateral damage of opening the economy. That's often how this is presented in lots of the conventional approaches. We think actually there's a better way. We think there's a way to increase well-being for the communities and grow economically at the same time. And so we just got to be a bit smarter about it, more inclusive about it, and we can get there. So let's just talk about public health first and the imperative to rethink. This is not just a nice to have, as Amol was alluding to. It's not just like, hey, we could do the trade-off red line, or we could do this. The trade-off red line is a really bad red line. And the reason is that, and this is not necessarily things that people focus on as much, the epidemiologists that we consult with, a range of experts, James Lawler of University of Nebraska Medical Center, he is the epidemiologist to the American Hospitals Association. And so if you think about any organization that needs to know, is there a second wave coming? What is the rate of infection? What is the rate of this? What's the rate of that? It's hospitals. And they turn to a set of epidemiologists that we have also turned to, we being a group of private citizens. In this case, just to be clear, I'm speaking as a private citizen today, not associated with any company or affiliated with any group, but just a set of private citizens and concerned citizens who are innovators and who really want to see good stuff happen. And I hope to count everyone here on this call today in that set of people right after this call. And so there's about 65 million people that will have been infected by about June of this year. And that's called the attack rate. And you might say, wait, Jack, 65 million people in the US, I'm hearing numbers that we just hit 1 million people. What are you talking about 65 million people? And the answer is, what you hear is the tested positive number. Those are people who got out to some testing facility and tested positive, and that's about 1 million people, and will be about 2 to 2.5 million people by June. And what the experts do is they take that number and multiply by 19, that's the generally accepted number in that expert community, to get the total attack rate. That is, after the first wave, how many total members of the total population have been infected. And of course, most of the people infected will never get tested. And that's because they don't have symptoms. If you don't have symptoms, why would you get tested? Number one. Number two, even if you had some symptoms in the past few weeks or months, you probably didn't get tested because you had mild symptoms. I know many, many people who stayed at home, had symptoms, went through it, flu-like situation, pneumonia-like situation, and got better. They never bothered to get tested. They called their doc. Doc said, based on your symptoms, you probably got it. Do this and this, you'll recover. And they recovered, and they're fine. And so the overwhelming majority of people in these kinds of pandemics do not get tested. And therefore, you have to look at the total attack rate, not at the total.
Well, and that 19x isn't just a rule of thumb. It seems to, there seem to start being some, sort of survey or mass testing based estimates that confirm roughly that, right? So people report the case rate for the test, how many tested positive, but that infection rate's probably quite a lot higher. 10, I guess 20 times higher. Yeah.
Right, about 19, 20 times higher. And so when people look at the fatality ratio, CFR, case fatality ratio, and just to let you know, the experts want to insist that it's the word ratio. Please don't say rate, otherwise they get a little upset. But case fatality ratio, which you'll see from the experts, they'll say, well, for COVID-19, it's about 0.3 to 0.5%. You might say, wait a second, 0.5%? What? I'm seeing numbers like percentage points, 3, 4, 5% in Italy or this place or that place. Again, the experts do not look at number of deaths divided by reported positive. They look at number of deaths divided by total attack rate. That is the 65 million number. So be that as it may, in terms of contagiousness, the experts tell us that roughly 25 to 30 million of these individuals will still be contagious around the June-July timeframe. We don't know exactly the total timeframe of somebody still being contagious post-symptoms. I can just tell you one anecdote as an example. My cousin, also named Jack as it happens, went through his symptoms. He's now 35 days after his final symptom left. He's better, 35 days. Just got tested 2 days ago, still positive. Got tested, swab test, positive after 35 days after last symptom. So there's a lot we don't know about this virus and about COVID-19. So before we make assumptions that everyone's okay after 10 days or everyone's okay after 14 days, we have to backtrack on those kind of assumptions. But in any case, to be conservative, let's say about 25 million people will be contagious, and the others now have gained some, not only immunity, but also are no longer contagious. How long would it take if we opened up completely as a society in the United States for 25 million people to infect the 250 million people that have not yet been infected? The answer, according to the experts, is not long.
Yeah. I mean, it'd be virtually overnight, right? I mean, in January, we had 100 people that turned into 25, 50. If 25 million are walking around like they used to back in December, it's going to be an avalanche.
That's correct. And so that's why in 1918, there's several reasons for this, but one of the primary reasons is that social distancing was relaxed after the first wave. You see the first peak over here of 1918. First wave was relaxed. The second wave was much, much worse. There are several factors for that, but the experts who've looked at this, Dr. Carter Metcher, Dr. James Lawler, Dr. Jay Schnitzer, these are all pandemic, epidemic experts, not just random MDs, but people who've dedicated their lives to studying the patterns of epidemic and pandemic. And anyone on this call who wants to speak to them, connect with them, please email me through Amol and through the team. And we're happy, and I'll provide my email at the end of this as well. Happy to connect you because I know there's a lot of misinformation about this out there.
So an anchor of your view is that last slide. I mean, in that waves diagram, when people have seen that in other press, they've probably not actually seen that July 18 bump. They're probably just looking at that first, the big one, and thinking, okay, that's the one we're dealing with right now, but that's actually the second wave.
Exactly.
Oh, by the way, there's a third wave, which is more than double the first one. Yeah.
Yeah. So the third wave is expected. So the second wave is expected in the US in the September timeframe, September, October. The third wave is expected in March of next year. And The hospitals, we're on the phone with hospitals a lot. We've been lucky enough to raise millions of dollars to help the hospitals in the hotspots of the United States initially. We hope to do international soon, but we've been lucky enough to go to some donors and raise money, and I've contributed a little bit and others have, but the majority has been contributed by great donors who we've been able to reach out to, and we've been giving money to hospitals in New York City as an example, and they've been very appreciative for the help because they are so underwater right now, and they are preparing for a second wave. The people who need to know, the beds, the ventilators, the oxygen, all this stuff are preparing for a second wave. So we can speculate all we want to, but the people on the front line, that's what they're doing. And so the question is, what do we want to do about that? What do we want to do about the fact that 25 million people in very short order would infect a lot of human beings, and we'd have a very bad wave? Even just say, I'm all for the argument's sake, we just had a wave equal to this one as it rolls now through the Midwest and through other places after New York and other places. That's still kind of bad, right? That's still not good. So we don't even have to go to apocalyptic scenarios to say we have a motivation to rethink. Okay, I think we all know, I'm not going to spend a lot of time on why the old economy is crap.
Just one more thing though, because this is so grim. It's like 50 times bigger, wave 2.
It's really, really bad, really bad. In this case, in 1918, it was about 5 times, 7 times as worse. In this case here, we're a much larger country now, many more people, much more density, more air flights that could happen, right? It's a very different scenario than 1918. And so the mixing of 25 million to 250 million, if you assume an R naught, which if people want to look up the R naught, that is the number of people that an average infected person infects. And we can have interesting discussions about which R naught we would use, which doubling rates we would use. I can tell you that the New Rochelle lawyer, who kind of helped kick things off on the East Coast, looks like he infected about 15, 20 people, who then each affected 15, 20 people. And that's possible. That R naught, that high R naught, which is very, very high, 10 to 15, is possible when you have naive populations, uninfected populations around you. Once most 80% of the population is infected, your R naught goes down. So you may see R naughts in the press of 2.5. And yes, the experts tell us that over 2-3 waves, after 80% of the population is infected, your chances of infecting somebody else are that you probably only affect maybe 2 people or 2.5 people. But during the period where 250 million people have yet to be infected, I mean, that's just like sitting ducks for you as an infected person as you go into the subway, as you get on the plane, bingo, right? We know of many cases in the early time of this pandemic where a single person got on a plane from Hong Kong, for example, to the US and infected 70, 80 people. We know, of course, of the various cruise ships and so on and so forth, and many other scenarios. So in largely uninfected populations, the experts tell us that the R naught could be much higher initially, even though over time it would go down. So this is the concern that we have, Amol. Yes, correct. Okay, the old economy had lots of issues. I think we all know about the binary trade-off that we were asked to do in the old economy on fossil fuels. Hey, Amol, what do you want? Do you want more growth in the economy and jobs, in which case you'll have to accept a lot of carbon intensity? Or do you want to reduce carbon, in which case we're going to have to pull back on the economy? Now, I'm not saying that's true or false choice, but that's the choice that many were presented in the old scenario. We think we can get beyond that. Education, lots of great opportunities, and education certainly a great leveler in social mobility, but let's admit that it was not equal access to all. And healthcare, the same thing in terms of access issues, and also going from a sickness to a more proactive community. So let's kind of get into some ideas here. I want to say at the outset, Amol, these ideas are not new. We didn't come up with these ideas. This is not novel ideas we drummed up out of some innovation engine. These have all been around for 20, 30 years. All we've done is try to compile them, crystallize them, clarify them, and say, how can we apply them to today's society? That's the novelty, if there's any, over here. just making it bite-sized and easy for all of us to take this deck. And please, everyone on this call, please take hold of this deck. We'll share around the link to it. Please transmit the deck to others. Please share it with others. This is meant to be shared with others.
So on this first piece, which is this like office distribution, we've already seen our customers, some of the really forward-thinking ones, begin to take steps that resemble this. A large financial services firm in the US, in the first week, so mid-March, late March, put in some requirements to Notel, even though they had all the offices they needed, but they asked Notel, hey, we need like 2-3 more offices in London, 2-3 more in New York. In the first instance, they were talking about something like disaster recovery, like, oh no, if we have an incident, we're gonna have to shut down and move everyone somewhere else. In the second instance, they started thinking, actually, we're gonna just segregate. We're gonna put critical teams in different places, even without an incident, to cellularize the risk. So
it's a great way to say it, cellularize the risk. Yep. So we've already been hearing a number of things. Again, I don't know from your mentioning, that's fine. Let's keep that confidential. But what we're seeing in our group is Jess Staley, who was actually the banker who took my first company public when he was at JP Morgan, now is the Barclays CEO and already made his announcements over the past week that, the entire bank is being run, quote, from the kitchens of his staff. And so certainly there could be a big readjustment in terms of location strategy. He's made that clear. We've heard that Bloomberg Philanthropies and Bloomberg.com are thinking about a number of strategies of taking offices in a number of different places. We're hearing about other banks that we've been in touch with to think about different strategies. And so there's a lot of different companies that are now thinking this through. It's not
but
just
on that one, they're not saying they want to run their bank from the kitchens long term.
Exactly.
I mean,
exactly. Yeah. Exactly. That's exactly our point. We don't want to work from home forever, right? Working in your pajamas and working with just a top on and shorts underneath that is fun for a little while, but people just do not want to do that forever. The dog is barking.
We just did a survey of 3 European markets among our customers and non-customers for UK, Germany, and France. The numbers were north of 80% on, I really want to be back at my desk.
Yes. So we agree with that. And that's why we kind of want to go with this third way. The third way is, if there's some people who want to stay at home, God bless them, that's fine. But for 95% of the population, they want to come back into some convivial atmosphere where there's some coffee, where there's some social interaction. People really enjoy that. In today's modern times, we get a lot of good interaction out of our work colleagues. And so we're suggesting, kind of this hub strategy where you have the HQ and you can still maintain your HQ if you want to, if there's a majority of people who do happen to live nearby or be within very close commuting distance. But for example, if you have a New York City-based bank and you have people in Hoboken and in Westchester and Long Island and Red Bank, New Jersey, and places like that, which banks do, then let's rethink that strategy. If you have a company in central London and you have people all over the greater London area, let's rethink that strategy. And could we have groups of 20 to 100 employees in these smaller hubs out there on the edge of a spoke and working really well for 90% of the time in those areas? Once every 2 weeks, they come to the main HQ for some presentation. Fantastic. But this is a way to de-densify. Companies, from the point of view of social distancing, want to de-densify their headquarters. Mathematically, you cannot do that if everyone who was there before is coming every day. So to de-densify the headquarters, let's have maybe only 30% of the people come who were coming before. Let's have the people maybe living nearby come to that one. And let's have other people at those outer hubs and distributed hubs. And it wouldn't be that hard to find the space. And those communities, frankly, would welcome it to have the economic development of having lots of employees close to home. They can go visit their kids. They can pick up their kids. They can be close to home, reduce their commute times by 70, 80%. The average commute time in America is over an hour now each way. And that's something that really cuts into quality of life and also obviously is one of the key drivers for air pollution, In many cities, it's well over half the air pollution of PM 2.5, particulate matter 2.5, is from automobiles. And so that leads to respiratory issues, which again is not a great idea, even in non-COVID times, increased cancer rates, according to the American Cancer Society, and of course, worse COVID outcomes. But even post-COVID, this is something that we want to really capture as a benefit from this period. If you look at Japan on lockdown in the middle and South Korea not on lockdown, you can see the clear distinction there for PM 2.5 air quality. Green is good, yellow and red bad. These were taken all last week. New York has not seen these green numbers for many years and decades. California has not seen these numbers for many years and decades. Do we want to give up this dividend? Do we want our kids to breathe bad air again? I would submit that we want to go forward and not backward. We've already seen the numbers in China. You can look at the pollution issues in China. And so I think that it's pretty clear there's a lot of quality of life, productivity, economic, business utilization, and health benefit to having this kind of model. Amol, I don't know if you have any comments on that.
Yeah, I mean, we have had a multi-decade drift towards highly concentrated HQs for very big companies in cities. And you know, this drawing is a campus. It's like a city campus, basically, which I guess fell out of favor at some stage in the 60s or 70s as people started trending back to cities. But a big tall office building is just a campus anyway, and you know, people on floor 7 and on floor 15 don't really feel that much more intimate than they would if they were at these spokes, much closer to home, lower commute time.
Right.
Yeah, but I mean, it feels easy for big tech companies to do it, I guess. I know everyone's had to go through the experiment right now. Is it practical? I mean, a bank is one kind of business. Can every kind of business consider this? Like, who are some of the kinds of companies you imagine?
Yeah, I think it's a great question. I think this, in a way, it's tied to the other things we're about to get into, because obviously knowledge working companies have a much easier time with this concept, right? But now the question is, what if you're not a knowledge working company? What if you have a healthcare company where normally you're seeing a lot of patients or you're interacting with lots of people in person? What if you still have a lot of forms that are being filled out in paper and pen, right? So insurance adjustments, insurance analysis, a lot of those companies. I spoke to a company in the last few weeks whose job in life, whose mission in life is to make the insurance industry paperless. And they've literally been in business for 20 years and they're still going because the mission is not yet accomplished, right? So when you think about, okay, let's say we are part of an insurance company, which is kind of a knowledge-oriented company, right? An insurance business is bits, it's information, right? And yet a lot of it is still physical in that there's site inspections at homes, there's site inspections to a car that got bumped up in an accident. Now, there have been movements pre-COVID. I know of venture-backed startups that say, hey, take a picture with your iPhone of the car damage, upload it to the website. And there's 3% of insurance adjustments that get insurance claims that get taken care of that way, 4%, 5%. So the question is, could we take this opportunity for that insurance company to say, hey guys, could you start to rethink how you do business so we can go contactless for your company and therefore move to this kind of model? So I think we have to realize and recognize that there's links, and not every company could just up and move and say, yeah, we're going to work in Westchester for 100 people and then only come in when we need to. There's still physical links that often happen because of old practices. So again, when it comes to healthcare, we're about to get to in a second, telemedicine, great idea, been around for 20 years, not new, not our invention. What was holding it back? A few things that I'll discuss in a second, but one of the first things that's holding it back is reimbursement. In 20 years, the telemedicine movement has tried to get the various payers and employers to reimburse for telemedicine, for a video call doctor visit. Couldn't do it. 45 days ago, all the payers said yes, unanimously, 45 days ago. So that's a dividend. Do we want to give up that dividend of a regulatory and structural change that just happened 45 days ago that now makes that industry so much more able to go contactless and get to this kind of situation where now a doctor.
Yeah, Jack, let's get to it. I mean, it is clear, and in a way, this is you simply soliciting the aid and support of Notel's best effort here, because certainly we can play a role to help companies reconfigure. Yeah, let's see where else.
Let me jump to telemedicine and then come back to some others. And so, I just want to note that it's clear that, obviously healthcare has not been evenly distributed. Even if you look now in terms of how different populations in New York are faring in COVID, they fare very differently. And access to healthcare is quite different. And so when you look at, again, what's happened in the last 5-6 years on the margins of society, not in the main column of the paper, but at the margins in newsletters about innovation and things like that, these are all FDA-approved devices. FDA-approved devices that, for example, in the case of Kinsa, it's an 8-year-old company. This is not a startup for COVID. This is a connected thermometer that not only is now being bought in the millions for COVID, but has been around for 8 years, started by public health folks in San Francisco to say, could we make a thermometer? But more importantly, could we make an app with some machine learning in it that then looks at all the thermometers on an anonymized basis and then finds clues where there's flu hotspots. This was influenza, of course, for the past 8 years. And they did that, and they created a company called healthweather.us, which you can check out. And they validated the signal of their millions of or hundreds of thousands of connected thermometers. And that helps public officials and also obviously helps the individual. And now an individual can have clinical quality grade information going to their doc, and be it an otolaryngoscope. I know this orange device doesn't look very familiar. People are more used to seeing it as that little metallic thing that you put in the ear or down the throat. If you're sick or if your kid is sick, ear, nose, throat kind of person, or an internist would use that. This is a version for home so that a non-trained individual can pop it into the ear and then transmit in real time that information to a doctor who's looking now down the ear canal or down the throat or other ENT applications. And of course, now EKG, AliveCore, and others, competitors, have now clinical grade EKG that can be transmitted in real time. Pulse oximeter is critical in the COVID scenario, but also post-COVID, and many others. I'm just giving you a smattering here, and there's many others here. Where I'm agnostic.
Yeah, I can imagine these being very relevant for other environments where people concentrate, whether it's schools or workplaces as well. I mean, I guess it was at the margins because it's like, oh, if you have a really special situation and you have lots of money, maybe you buy one of these things to manage yourself. But suddenly everyone needs to monitor temperature or maybe even oxygen, right? It's an indicator of how you're doing.
That's correct. So right now we have a program in the COVID era where our donor group, we bought thousands of these pulse oxes as an example, distributed out to communities of need. And then they're being managed remotely by docs and nurse practitioners to say, what's your pulse ox? What's your O2 sat rate in your finger? And if it's good, it's above 90, great. You can stay at home. Don't come to the hospital. Don't get even more sick. Stay at home. Be cared for at home. And so these are critical life-saving devices. But post-COVID, that's really what we're here to discuss. This becomes a transformative technology, and particularly when it's connected to sites like Accurex in England, Teladoc in the US, where now you can pop up your doctors receive that information from you. And now again, we can move to a wellness scenario, not just a sickness scenario of a healthcare system, where it's not just because I'm ill that I'm calling you Ms. Doctor, but I also am calling you now because I want to do my monthly wellness check-in. And I want to say, hey, here's my blood pressure, here's my EKG, here's my pulse ox, here's all my information. Let's do a wellness checkup right now, right? And I could do that from my office, from my home in 15 minutes with you. I'm all sitting there as a doctor. We can have that chat and I do a check-in. We readjust my vitamins, whatever I need to do. We're also thinking about phlebotomy networks. Phlebotomists are people who have the ability and training to come to your home or office, draw some blood. They centrifuge it with a little portable centrifuge on their shoulder, and they send it off in an ice pack. Those networks already existed, again, in the margins of society. But I have used those for loved ones where I've sent phlebotomists, these mobile phlebotomists, to houses and to offices of loved ones of mine, and drawing blood, getting that blood into the lab, getting it done within 24 hours and getting those lab results. All this can be done. There's even an ultrasound device that can be sent to the home on a loan basis, ultrasound yourself, send back the data, and send and return the ultrasound device.
And the first test drive on all that is already underway. And I guess if we're going to find out if 25 million or 100 million or 200 million people have the virus in the US, people are going to take the test at home. I mean, I have a doctor friend who let me sign up for his trial, and I got a FedEx. There was some stuff in the FedEx. I put the swab in my nose, mailed it back, and I found out I'm negative. Okay, that's good. And now he's got his antigen test getting ramped up as well.
An antibody test, yeah.
And I'm gonna have to prick my finger, like, you know, maybe like a diabetic monitoring blood, but I mean, it's not that hard to do, and I guess we'll need millions of those. Everyone will have done one of these at some point.
Right. If people can see this little thing on the upper right-hand corner, you might have the Zoom videos on top of your right-hand corner, but if you move that a little bit, you can just see the, this is a glucometer in this case here, where you do a pinprick and you get your glucose reading in this little device, but that could equally be a pinprick for antibody or things like that. So, you know, the vision of the near term, not the future, I keep saying the future, is yes, there'll be lots of pinpricks that one could do at home for a variety of things that you can have. But glucose obviously is one of them. This antibody test, once it's validated, could be another one, and things like that. But here's the good news. These are FDA approved. Now, the big thing is that we have reimbursement. We have reimbursement. And so one of my calls in a few hours is with one of the major hospitals in New York City, a 4,000 bed hospital that is doing a lot of telemedicine, not because they plan to, but because they need to right now. And they got their 900 docs on a telemedicine platform to do video, but they're not using one of these devices yet because, again, they weren't prepared. It wasn't part of their MO. It was, you make an appointment, you see the doctor on Monday and Wednesday in their private clinic, and then Tuesday and Thursday, they make their rounds on their hospital patients. That's how lots of research hospitals are set up. Monday, Wednesday, private clinic. Tuesday, Thursday, hospital rounds. Friday, research papers, right? That's many doctors in research university settings, that's their life. And we can help them be more productive and engage with a wider set of patients so that one hospital can now become a hospital for a much wider region. In fact, maybe even nationally, if they have certain specialties, if they're the Mayo Clinic or certain very specialized clinics like Cleveland Clinic that have great specialization in cardiac, and they want to serve people coast to coast across the nation.
Well, and then it's dramatically lower cost. I mean, you use the word productivity, and that translates to less cost per patient,
right?
Which I guess is the accessibility problem that you were just describing. So accelerating the adoption on this stuff. Suddenly it can be reimbursed. Suddenly every single doctor has done a FaceTime now in the last 2 months, and and now they got to get these gadgets out there.
Yeah. And so now, we come to the question of access and inclusion, because the healthcare system is not inclusive. There's very differential healthcare if you're sitting in a Native American tribal region than if you're in the middle of a big city in America. Even within big cities, Queens has been very hard hit with COVID, and the access to healthcare in certain parts of New York City are very different than other parts of New York City. And so one thing I want to be very mindful of, and a big thrust of this work, is not just how could we get people who have some money to pay $300-400. If we add everything up here on this slide, it's, let's call it $400, right? Well, guess what? Not everyone has the $400. What are distribution channels, creative distribution channels that we can use? So I was on the phone with CEOs of companies over the last week and a half talking about this idea. And I think that self-insured employers, the majority of the Fortune 500 are self-insured. And if they can offer this as a package that they pay, that they take care of for their employees, they will save money on their self-insured account, right? Because they're the ones who bear the brunt of all sickness for their employees. And if they roll it out over maybe 3 years and they amortize it out that way, I think it could be quite affordable for them. And again, a cost savings to them, not just a nice to have goodwill gesture, although it is, but something that would actually save money and change the face of healthcare for their people.
Yeah, so that it's a layer of sort of employee benefit that has been tiptoeing into the workplace rather gently this last couple of years.
That's a nice way of saying it,
for its
rather
own
gently.
customers. And many of our customers directly, they employ some of these, like, text message based screening kind of primary care
Yeah.
filters. But it could go way deeper than this. And if I was a forward thinking manager, I guess I'd want to have this kind of stuff available. Very rudimentary ideas have already been put out there about, like, checking temperature in mass kind of at ingress and egress locations and things. But perhaps more close monitoring for your entire staff is something quite valuable, both the testing and then things like temperature.
Yeah, for sure. I just want to address the temperature at the lobby scenario, and I know that China does that, and it is an intervention. I just want to kind of address it, though. We have asked a lot of experts around that. Let's be super clear about what the experts have determined already, which is that people who are afebrile, no fever, no elevated temperature, both before symptoms approach and then after symptoms approach, can and most likely are contagious. So I want to kind of be clear about that in case
Right, which is like
listening,
8 out of 9 or 9 out of 10 of infectious people have no temperature. So if all you're doing is checking temperature,
that's correct.
You're barely in the game. And actually, you're just giving a lot of, you're giving a lot of false negatives to folks, right? Because you might have found someone's temperature, but everybody else who's still infected, they think they're fine. They're going to go and, pack a box or deliver some food. It's not.
That's correct. That's correct. So I just want to kind of be upfront about that. So having people with their own connected thermometer is great, but also having people with other devices such as pulse ox. Many people have no temperature and no other clear symptoms, but their pulse ox is dropping dramatically. And there's a phenomenon in COVID right now that the doctors have termed happy hypoxemia. Happy hypoxemia. This is referred to the condition that they find many patients in upon presentation, which is they're talking, they're on the phone, how you doing? I feel great. I've got this slight issue where maybe they have one of the other symptoms, so that's why they're presenting. They put the pulse oximeter on, and they're like at 80 or 75. Okay, below 90 is like alarm bells, like ding, 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 ding. Okay,
wow.
And they're talking. They're at 70, and they're talking on the phone. And the doctor's like, how is this happening? This is a conundrum. That's why they call it happy hypoxemia.
Yeah, so, right, because usually oxygen, as it goes down, don't you just get tired? And
you faint. You will go out, So that's not happening here. There's something unusual about the COVID attack on the lungs. Again, the virus, to recall and to remind ourselves, the virus is the SARS-CoV-2 virus. It attacks, and then you get the COVID disease. One's a disease, one's the virus. And then one of the areas it attacks any cell with an ACE2 receptor. And it happens to be that our pneumocyte type 2 cells in our lungs, in the alveoli, the little sacs, happen to be rich in ACE2 receptors. And so that's probably why this is a respiratory disease in the main, because of the richness of those type 2 pneumocyte cells that have ACE2 receptors. Virus locks in, gets in, rejiggers, and you lost the ability to do the activities of the type 2 pneumocyte, in part, which is to create something called surfactant, which helps you breathe and is the reason why all of us are breathing and alive today on this call. So this is something that...
So what should we be testing for? So if we're going to, the potential scaling of infections is gobsmacking, and governments are going to be too slow. Clearly, the workplace is a site where we have some level of control and we can do better. Checking for temperature seems like a waste of time.
I think if I had to pick one thing, I know many employers right now in the small business, innovative, kind of startup category that are handing out pulse oxes to their people. You're talking about a $50 device. This is not expensive. You can splurge for the $70 device that is Bluetooth enabled if you want to, and to send continual monitoring to your doc. But at $50, that's going to be, and again, what I would argue is that
you don't live your whole day with your finger in there. You probably just check it a couple times a day.
It's an intermittent check. I would, if people feel like they're in a vulnerable category, if they feel there's other kind of symptomology, they probably want to check twice a day, 3 times a day. It's not hard. It's 30 seconds. You check it.
Yeah.
Done.
And there's got to be a mass virus test at some point soon, a swab test that you could do on site and mail off and do
Yeah,
batches every day, you get results, right? And then at some point the antibody, but that one's further out. How,
that's
how long
correct.
before how long before I can order 1,000 swab tests to keep in the office so that my 100 staff can take it
Well,
every
right now there's a
day?
big shortage, but a number of people I know working on it. I would say that by September, certainly by the fall, I think we should see ample supply of both the swab test, known as the RT-PCR test, and also the antibody test, which is the serology, which is the blood test that people are
Yeah.
hearing.
So one
I
of
think by
them does like a PCR, it does like a DNA analysis of your mucus, and you got to send that off. And the
right,
blood test checks for some biomarkers floating in your blood that are your antibodies that
that's
show that you
correct.
had it at some point recently.
Right
And then if
now,
you have
again,
both, you probably don't need both, do you? You just need one, the
yeah, I
other.
mean, ultimately, once the blood test is validated, one, and two, once we understand the signal, that is, does having antibodies actually confer immunity? Question. Second question, how long does it confer immunity? It's not clear that it's any longer than maybe even just 10 to 12 weeks. So we don't know that answer. But I think by September, October, I'm cautiously optimistic that we'll have a lot of those answers. So I think the
Mhm.
fall is a time frame in which a lot of people can get some answers around, do they have antibodies? How long is that immunity for? If it's only for 10 weeks, then that means that they still have to be super careful, right? Depending on when they got it.
And you
And
should be doing track and trace type stuff, right? I mean, a workplace has access controls. We know who was there that day. We know who the guests are. If
right, right.
100 people take the test on Tuesday and you find out Wednesday that actually one of them had it, all 100 and any other guests need to know
Yeah, yeah.
to
I would
quarantine.
encourage people for the workplace practices to hold off on having any non-employee visit the office for a longer period of time than people are in the office. And what I mean by that is that you can do things with your own employees that's very hard to track down that a guest came, because how are we going to contact that guest? Do we have the contact information? Are we allowed to do that? There's privacy issues. With employees, you're allowed to have contact with your employees and allowed to have a conversation that, hey, one of our other employees got infected, so we want to let you know about that. In terms of a
Right.
guest, that becomes a very, very different kind of ball game. So if we
Yeah.
can encourage offices as they open up to not have external guests, that would be great. That would be great. Yeah,
Mm.
yeah,
Mm.
yeah.
So to summarize the themes that we've been covering, because I don't know that we'll have a chance in our conversation here to do education and
Yeah, I just want to
resiliency.
mention briefly. Please check out the slide deck for hybrid online offline education ideas. I'll leave that to the future, and then also please check out for supply chain. That's less relevant, I think, for today's conversation. But how do we make resilience scores on products that we buy, be it B2B or B2C? But with that, happy to engage. Again, please try to share this deck if you can with others. We're doing this as private citizens. This is not being represented by any company out there. We want this to be something that just spreads organically across the society. Please share it with influencers and others. And Amol and Musa, if you can share this link with folks, that would be great.
Yeah, certainly with our clients. And we have a role to play in serving our customers, but also trying to help shape what the answer is. I've been dealing with customers of ours that have 500 offices around the world, 600, whatever, tens of thousands of employees, and we might only serve them on a few of their locations where we're running something for them, but they haven't figured out what they want to do. I mean, they're just in this sort of immediate time frame, and they don't really know what they're doing next. I mean, the shape of your comments here are you got to de-densify, you got to decentralize into some more hub-like format, and perhaps even use those workplace venues to deploy a whole new kind of monitoring and healthcare that's possible. And we get a bunch of bonuses, right? We get a benefit for carbon, and we get a benefit for access to healthcare.
Yeah, I would agree with that. Again, if we can make a more inclusive society as we do this, I think that's going to be a tremendous benefit for everybody, both people who were included before and those who were not. And I think that's possible. I think actually we can do that with strong economic growth. And that's, again, what we want to counter. There's a narrative out there of a false choice, a choice that chooses either well-being or economic growth. We think that's a false binary choice. We hope that we can engage as many of the audience members here today as ambassadors with us to share these ideas and say, hey, I think there's maybe a better way. Let's experiment, you know, and if I was just—
So what's our next step, Jack? I mean, people are just going to email. How does this thing get more freight behind it? Should we, I mean,
well,
I
here's what
think
we'd
for
love to
our
do.
teams, we're certainly going to be starting to think about the themes that we talked about here and productize them, essentially.
Yeah, we should, as many companies like Knotel and others should productize these ideas, number one. Number two, if there are more engagements like this where we have a few hundred people who want to gather up on a Zoom call and we want to talk to them, please invite us. There's several of us who can give this talk, not just myself and Amol. You can give the talk. Please feel empowered to give the talk. So this is not proprietary. This is open source. Take this deck, slice and dice this deck, make it your own deck. We don't need credit. You know, take this as your own into your communities, refashion it for your communities, and take it from there. Second, if there are policymakers, politicians, or others that you can engage with to plant these seeds, we know that there's so much pressure on the politicians, city, state, federal, to open up things, and we understand, and we're empathetic with that pressure that they're feeling. Could we get this in front of them at every level? This is not just a federal government level. This is at every single level of government. If you're in any way connected to somebody on a local school board, if you're connected with somebody in the local city council of a population of 100,000, that's great. Start there. Nothing is too small to start with. And I would encourage folks to kind of share this in their communities, get this out there. Please ping me, please ping them all. Please ping us and with your ideas. We'd like to extend this. We're not saying these are all the ideas either. I know there are a lot of other ideas that people have that are also great ideas, and please help us incorporate that in this deck and get that out there. So thanks, Amol, for hosting today.
We will email everybody who joined just with the link and the landing page for some of the other materials, both your document here and the recording of the webinar, if you want to share it with other folks. And Jack, you and I are certainly going to be together again soon on this. I even see Yossi Vardi among our attendees here. Hi, Yossi.
Hey, Yossi.
So we'll get ourselves out to Israel as well, and to Europe generally, and maybe talk to some audiences there. Thank you very much, Jack. It's been enlightening. We have a lot to do.
Thanks, guys.
Thanks, Jack.
Bye.
Musa, you there?
Yes, sir.